Madam, we are live now.
Okay.
Hello.
Hello.
Yes, madam, we can start the session. We are live now.
Yeah. I'll start.
Yes, madam.
Okay, okay. Is it visible?
Yes, madam, your slides are visible.
Well, thank you for giving me this opportunity. Good afternoon, all. This is Dr. Aarti from Bhubaneswar, Odisha. Well, my topic is recurrent pregnancy loss, current perspective. Recurrent pregnancy loss is a challenging situation for the obstetricians and a distressing event for the patient and her relatives. It is a debated topic and the definition differs among the international societies. According to ISAR, the definition of recurrent pregnancy loss is when there is 3 consecutive pregnancy loss, including non-visualized ones. But according to ASRM, that is American Society of Reproductive Medicine, it is defined as 2 or more clinical pregnancy loss, but not necessarily consecutive. So according to ISAR, it is 3 consecutive pregnancy losses, including the non-visualized ones. And according to ASRM, it is 2 pregnancy loss, 2 or more clinical pregnancy loss, but not necessarily consecutive. The risk factors for a recurrent pregnancy loss are maternal age. With increasing maternal age, the quality of oocyte reduces, and there is chances of increased incidence of recurrent pregnancy loss. And with increasing number of previous miscarriages, the risk also increases. When there is 3 consecutive pregnancy loss, the risk will be 40%. Obesity is one of the important risk factors. Then endocrinal factors, then exposure to some environmental toxins like cigarette smoking, caffeine, and alcohol consumption, parental and fetal karyotypes, and uterine factors. As I was telling, with increasing maternal age, the risk of RPL increases. When the age of the mother is more than 45 years, the risk will be 93%. These are the causes of recurrent pregnancy loss. Around 40 to 50% of RPL are unexplained. 17 to 20% are because of endocrine factors, 20% because of autoimmune factors, 0.5 to 5% infections, 10 to 15% of RPL are because of anatomical defect of the uterus, and 2 to 3% because of genetic abnormality. After fertilization, 60% of cases land up into preclinical loss. And out of 60%, 30% pregnancy loss because of failure implantation. Another 30%, there will be early pregnancy loss. So only in 25% there is live birth. So these are the anatomical defects. There are some congenital causes. There are some acquired causes. Congenital, that may be septate uterus or bicornate uterus or unicornate uterus, or didelphic uterus, or arcuate uterus. That can be diagnosed by 3D ultrasonography, or sonohistography, or hysterosalpingography, or hysteroscopy, or by MRI. Acquired causes of anatomical defects of uterus are because of intrauterine adhesions, myomas, or polyps, or cervical incompetence. Intrauterine adhesions because of curettage, or previous uterine surgery, or previous infections, or following complicated birth. Myomas, mainly submucosal myomas or intramural myomas, that cause anatomical defect of this uterus. Septate uterus is the most common type and is associated with spontaneous miscarriage. There is evidence to suggest that there will be improved pregnancy rate following hysteroscopic septum resection, and it is recommended to remove the septa surgically by hysteroscope. Metroplasty is not recommended for uniconvate uterus. It is highly controversial for didelphous uterus and is only recommended as a last resort for biconate uterus. Histoscopically resected submucosal myoma contributes around 4 to 5% of RPL, and that should be removed surgically, mainly by histoscopy. And polyps, that contributes around 2 to 3% of RPL, and that should be removed. Unicornate uterus, available evidence suggests that most pregnancies best managed expectantly with encercles, and that reserved for those with previous second trimester pregnancy loss or evidence of progressive cervical shortening and dilatation. Biconate uterus, surgery generally considered unnecessary and best reserved for those with a well-established history of otherwise unexplained recurrent pregnancy loss or previous births. Previable births. Uterine leiomyoma. All myoma do not require surgery. Myomas that occupy the uterine cavity that needs surgery, and that should be removed histoscopically or laparoscopically, or sometimes abdominally also. Then chronic endometritis. It is defined as chronic inflammation of the endometrial lining. The prevalence is 10 to 27%. Here what happens, there is impairment of endometrial receptivity that occurs due to infiltration of stroma by plasma cells, and there is altered expression of genes that are responsible for implantation. The gold standard for diagnosis is identification of plasma cells in the endometrial stroma. Several infections have been investigated as potential cause of early miscarriage, that is bacterial vaginosis, brucellosis, syphilis, cytomegalovirus, human immunodeficiency virus. However, no causal link has been established, and it is not recommended to test or empirically treat asymptomatic women with recurrent pregnancy loss. Given the lack of conclusive evidence, several international societies do not include screening for chronic endometritis in their recommendations. Then immunological factors. Antiphospholipid syndrome is characterized by the presence of antiphospholipid antibodies and has long been associated with recurrent pregnancy loss. The prevalence is as high as 42% to as low as 6%. Overall prevalence is 5 to 20%. It is a prothrombotic state or thrombophilia that predisposes an individual to thrombosis or formation of clots. This is again two types. One is inherited, another is acquired. The inherited causes of antiphospholipid syndrome are because of deficiency of antithrombin, or protein S deficiency, or protein C deficiency, or mutation of factor V Leiden, or prothrombin G20120 mutation. The acquired causes are antiphospholipid syndrome primary or secondary with concomitant autoimmune systemic disease like SLE. Inherited thrombophilia and RPL. Routine screening of women for inherited thrombophilia in absence of any thromboembolic episode is not recommended. And treatment of women with RPL and inherited thrombophilia by prophylactic anticoagulants have not shown any significant benefit as regards pregnancy outcome is concerned. So, treatment of inherited thrombophilia with RPL by prophylactic anticoagulant is not essential in any significant benefit as regards pregnancy outcome is concerned. Acquired thrombophilia and RPL. In women with RPL, 5 to 15% may be because of presence of this antiphospholipid antibodies. Antiphospholipid syndrome workup for women with RPL. We have to do assessment of anticardiolipin antibodies, that is IgM and IgG, lupus anticoagulant, and anti-beta-2 glycoprotein antibody, that is IgM and IgG. And it is indicated in all women with recurrent pregnancy loss twice 12 weeks apart. So we have to do workup for lupus anticoagulant, anti-beta-2 glycoprotein, and anticardiolipin antibodies 12 weeks apart. Then what is the pathogenesis of antiphospholipid syndrome? First, there is formation of thrombosis at the uteroplacental circulation because of vascular insufficiency. There is direct adverse effect of these antiphospholipid antibodies on the function of placental trophoblast, and that decreases its viability and invasive properties. It affects the production of hormones and it induces inflammatory response in the placental tissue, as in other autoimmune diseases. Then how to diagnose this antiphospholipid syndrome? For diagnosis of antiphospholipid syndrome, the lady must have one clinical criteria and one lab criteria. The clinical criteria are again vascular thrombosis and pregnancy morbidity. Vascular thrombosis is one or more clinical episodes of arterial or venous thrombosis. Pregnancy morbidity is one or more unexplained death of morphological normal fetus, that is more than 10 weeks. One or more premature birth at less than 34 weeks due to preeclampsia or uteroplacental insufficiency. 3 or more unexplained consecutive spontaneous abortions before 10 weeks. The lab criteria includes presence of lupus anticoagulant on 2 or more occasions 12 weeks apart, presence of anticardiolipin antibodies on 2 or more occasions 12 weeks apart, and presence of anti-beta-2 glycoprotein on 2 or more occasions 12 weeks apart. So for diagnosis of antiphospholipid syndrome, the lady must have one clinical criteria and one lab criteria. For treatment of women with RPL and antiphospholipid syndrome, the mainstay of treatment is antithrombotic therapy, that is anticoagulation and aspirin. We have to do careful maternal and fetal monitoring for early detection of complications like growth retardations and pregnancy-induced hypertension and oligohydramnios. And we have to do scheduled delivery at 38 weeks of pregnancy or earlier if it is essential. And we have to stop aspirin 7 to 10 days prior to the delivery and switch from low molecular weight heparin to unfractionated heparin and stop unfractionated heparin 6 to 8 hours before delivery to prevent formation of hematoma. And during postpartum period, we have to give thromboprophylaxis. Then on antithrombotic treatment, that is low dose aspirin, we have to give 100 to 150 milligram per day. And it is started when conception is attempted. And it is stopped anytime after 36 weeks, usually 7 to 10 days prior to delivery. Then low dose heparin, it is started once pregnancy is confirmed. And heparins are preferred as they do not cross placenta and do not cause fetal anticoagulation. Low molecular weight heparin is preferred to unfractionated heparin except near term. And oral anticoagulants like warfarin is avoided because of its side effect, like it causes teratogenesis of the fetus and it crosses the placenta. Then what is the prophylactic dose of this heparin? And this prophylactic dose of anticoagulant therapy is given in women with recurrent pregnancy loss and antiphospholipid syndrome without prior history of thrombosis. The dose is low molecular weight heparin, that is enoxaparin 40 milligram, or deltaparin is given subcutaneously once daily. And during delivery, or during delivery, unfractionated heparin is given, that is 5,000 international unit subcutaneously every 12 hours. Whereas therapeutic dose of anticoagulant therapy is given in pregnant women with recurrent pregnancy loss and antiphospholipid syndrome with prior history of thrombosis. Then the dose of low molecular heparin is, that is enoxaparin 1 milligram per kg body weight, and during delivery and during labor, unfractionated heparin given, that is 250 unit per kg body weight subcutaneously every 12 hours to keep APTT in the therapeutic range, that is 1.5 to 2.5 times. Then how to monitor this anticoagulant therapy? Women on prophylactic dose of low molecular weight heparin or unfractionated heparin doesn't require regular monitoring, but women on therapeutic dose with low molecular weight heparin also, no specific monitoring is essential. Some monitor by anti-factor 10A activity, that is 4 to 6 hours after last dose to maintain it between 0.6 to 1 units per ml. And women on unfractionated heparin, they are monitored by APTT 6 hours after the last dose and maintain APTT between 1.5 to 2.5 times and monitor every day till target reach, then every 1 to 2 weeks. Then what are the complications of these anticoagulants? The most important complication is bleeding. Then that can be neutralized by using antidote, that is protamine sulfate. Then another thing is heparin-induced thrombocytopenia. That is rare. Then stop heparin and switch to other non-heparin anticoagulants. And heparin-induced bone loss also, that is a serious complication. So women on heparin should advise to take regular calcium and vitamin D supplements and should advise to do weight-bearing exercises. So management of antiphospholipid syndrome with RPL with poor outcome despite antithrombotic therapy, in that situation, hydroxychloroquine with dose 200 to 500 milligram started 3 months prior to pregnancy, but the evidence is very poor. Then coming to the endocrine causes. Hyperprolactinemia is associated with infertility and miscarriage by altering the hypothalamus pituitary ovarian axis, thus leading to impaired folliculogenesis and anovulation. Treatment of idiopathic hyperprolactinemia with dopamine agonist that significantly decrease the miscarriage rate compared to no treatment. However, the live birth rate were comparable. Thyroid disorders, especially hypothyroidism, have long been associated with infertility and adverse pregnancy outcomes and recurrent pregnancy loss. The most commonly used serum thyroid stimulating hormones threshold to define subclinical hypothyroidism is 2.5 milli-international unit per liter. Despite the lack of RCTs, it is recommended to keep TSS less than 2.5 in these patients. Some studies shows that there is an association between thyroid antibodies and recurrent pregnancy loss in euthyroid patients, with evidence of a trend toward decreased miscarriage following treatment. But to date, there is insufficient evidence to recommend routine screening of thyroid antibodies in euthyroid women with RPL. Then PCOS is associated with increased risk of miscarriage because of insulin resistance, because of hyperinsulinemia and hyperandrogenemia. Metformin, an insulin sensitizing drug, is commonly used in women with PCOS and has been shown to improve weight management, glucose tolerance, and that reduce androgen productions. But the use of metformin to reduce miscarriage in women with PCOS have yielded conflicting results, and there is insufficient evidence to recommend it for RPL. However, metformin is frequently prescribed in women with PCOS, is safe during pregnancy, along with weight loss, could be useful to PCOS patients with RPL. Then abnormal glucose metabolism. Screening with glycosylated hemoglobin levels is recommended for all women with recurrent miscarriage. This has replaced the oral glucose tolerance test in the first trimester. Strict glycemic control is desirable prior to pregnancy with glycosylated hemoglobin levels less than 7 in patients with over diabetes. Then luteal phase deficiency. Several diagnostic criteria have been used over the years for diagnosis of this LPD. However, diagnostic tests for LPD are neither reproducible nor reliable and have not been validated in large studies and are thus not recommended in clinical practice. There is also no consensus on the proposed management of LPD. Progesterone supplementation is the most widely used treatment because of its availability, ease of administration, and tolerability. Then genetic factors. Majority of early pregnancy loss, that is 50 to 60%, are the consequence of chromosomal abnormalities. And most common parental abnormalities are balanced translocation, that is 2 to 4% cases of RPL. And out of that, 60% are reciprocal translocation and 40% are Robertsonian translocation. Embryonic aneuploidy is the most common cause of early pregnancy loss. That can be trisomy, polyploidy, or monosomy X. Maternal age and aneuploidy, there is a strong correlation between advanced maternal age and autosomal trisomy. But there is no significant association between advanced maternal age and rates of sex chromosome monosomy or polyploidies. The largest effect of advanced maternal age is seen in trisomies involving small chromosome, that is 8, 9, 10, 13, 14. There are 3 important genetic causes responsible for recurrent pregnancy loss, that is spontaneous fetal aneuploidy, balance and Robertsonian translocation. Another is sperm DNA fragmentation. Should we advise karyotyping of POC in all cases? Then my answer will be no. The current recommendation for genetic testing is parental karyotyping is not routinely recommended in couples with RPL. It is given by ISAR RPL guideline 2017. Once again, I repeat, parental karyotyping is not routinely recommended in couples with recurrent pregnancy loss. This is given by ISAR RPL guideline 2017. CGS microarray, that is comparative genomic hybridization microarray testing of fetal tissue, is necessary in patients with more than 2 pregnancy loss at less than 20 weeks gestation. It is given by SUG practice guidelines November 2019. So once again, I repeat, SUG practice guideline in 2019, they have given that CGS microarray, that is comparative genomic hybridization microarray testing of fetal tissue, is necessary in patients with more than 2 pregnancy loss at less than 20 weeks of gestation. CGS microarray testing is the most recommended test for genetic testing. There are several tests for genetic testing. One is fluorescent in situ hybridization. They are using chromosome 5 and 7. It is inexpensive. And karyotyping, it needs viable chorionic tissue. It is time consuming. There is possibility of maternal contamination. CGS microarray, it is the most recommended test. It uses non-viable tissue and it can detect single gene defect. and all chromosome can be studied. Then another excitement for genetic testing is next generation sequencing, which uses non-viable tissue and it avoids maternal contamination. What is the advantage of this genetic testing? It is just an explanation of the cause of miscarriage that will elevate the stress in the mother. Then sperm DNA fragmentation. This is another important cause of recurrent pregnancy loss, and couples with a history of RPL showed a higher incidence of sperm DNA fragmentation and poor progressive motility of the sperm. These findings indicate that testing for DNA fragmentation has a certain predictive value in the assessment of prospective risk of recurrent pregnancy loss. So it is necessary to perform an sperm DNA fragmentation test in couples experiencing recurrent pregnancy loss. It is not widely accepted as part of the evaluation of infertility or recurrent pregnancy loss because of expensive equipment is essential and because of lack of information. Then what are the treatments of these genetic factors? So we can do genetic counseling. We can do ART, including PGT, that is pre-implantation genetic testing. Then use of either donor oocytes or donor sperms, depending on the affected partner. Then unexplained recurrent pregnancy loss. After doing complete evaluation of genetic factors, anatomic factors, endocrinal factors, and immune evaluation, and if everything comes normal, then that case is known as unexplained case, cause of recurrent pregnancy loss. The overall incidence of this unexplained cause of recurrent pregnancy loss is 40 to 50%. And the most important cause is because of deficient immunosuppression. That is deficient immunosuppression. Here what happens, there is increased maternal T helper type 1 cytokines and decreased maternal T helper type 2 cytokines. What are these cytokines? I will tell you. Cytokines cytokines are the messengers of immune system, like hormones in the endocrine systems. In T helper type 1 cell response, there are two types, many cytokines are there. They are tumor necrosis factor alpha and interleukin 2. And in T helper type 2 cell response, the cytokines are interleukin 4 and interleukin 10. T helper type 1 cytokines that trigger a thrombotic or inflammatory process at the uteroplacental circulation by activation of vascular endothelial cell procoagulant. Whereas T helper type 2 cytokine that inhibit T helper type 1 induced tissue destruction by monocytes. And tumor necrosis factor is supposed to suppress the growth of the trophoblast by inducing apoptotic change in these cells. Is progesterone the missing link? Yes, progesterone is the missing link. Another important cause of this unexplained cause of recurrent pregnancy loss is inadequate perfusion that leads to implantation failure, or that is detrimental to the early embryonic development. That can be diagnosed by uterine artery perfusion by using uterine artery Doppler, which regulates endometrial receptivity. As I was telling that there are two types of cell response. One is T helper type 1 cell response. Another thing is T helper type 2 cell response. In T helper type 1 cell response, there is abortion of fetus, whereas in T helper type 2 cell response, there is protection of fetus and continuation of pregnancy. What happens in T helper type 1 cell response? There is formation of symmetric antibodies, and that causes exact alignment between binding surface of these paternal antigens and maternal antibody. That causes activation of this complement cascade, and that causes abortion of the fetus. In T helper type 1 cell response, there is release of tumor necrosis factor and interleukin 2, and that further activates the natural killer cells that stimulate the lymphokine activated killer cells, and that causes abortion of the fetus. This is known as cascade reactions. In normal pregnancy, first there is activation of progesterone receptor, and that causes stimulation of a progesterone-induced blocking factor that blocks the cascade reaction, and that shifts the cell response from type 1 to type 2, and there is protection of this embryo, and there is continuation of the pregnancy. Progesterone-induced blocking factor, it is produced after activation of progesterone receptor. It is produced by the CD56 cells, and it supports the T helper type 2 cell response. It reduces the activity of natural killer cells. So coming to the treatment of this unexplained cause of recurrent pregnancy loss, paternal cell immunization, third-party donor leukocytes and trophoblast membrane, and intravenous immunoglobulins. But all these have got limited value. And intravenous immunoglobulin, it is indicated in autoimmune disorders. It is indicated in antiphospholipid syndrome if miscarriage occurs while on aspirin and heparin. Intralipid also, it can be given. It is soy lecithin extract used for parenteral nutrition, and it's cost effective, and it is used also controversial because of adverse reactions. So coming to the conclusion, recurrent miscarriage is a complex condition. It requires consideration of multiple factors for appropriate workup and management. In the clinical setting, though a thorough physical examination and testing is recommended after 2 consecutive miscarriages, majority of miscarriages are sporadic and thought to result from genetic abnormalities of the embryo, which are influenced by maternal age. Routine investigation after 2 consecutive miscarriages include hemogram, glycosylated hemoglobin, TSS, prolactin, and transvaginal sonography, preferably 3D. Sonohistography is also essential. Antiphospholipid antibody test, that is leucose anticoagulants, anti-cardiolipin antibody, and anti-beta-2 glycoprotein antibody 12 weeks apart. Specific cause-related treatments should be given. Treatment of possible causes like surgical treatment and supplementation should be given. In spite of thorough evaluation, in more than 50% of women with RPL, the etiology remains unexplained, and the approach needs to be individualized and tailored according to the patient. So finally, tender loving care should always be given to the patients. So thank you. Thank you.
Hello.
Hello.
Yes, madam, there are some questions also. So I will
Yeah.
be posting one by one questions.
Yes.
Ma'am, first question has been posted.
The first question is, how is inevitable miscarriage treated? I think inevitable miscarriage is the os is open. So in that situation, we cannot continue the pregnancy. We have to terminate the pregnancy by doing suction and evacuation. What is the likelihood of a successful pregnancy following an successful pregnancy following an early pregnancy loss? It depends upon the cause of the recurrent pregnancy loss. If it is genetic factors, definitely it will recur. And unexplained, also it depends in anatomical factors. After treatment, the success will be high. So it depends upon the cause. How is early pregnancy loss differentiated from ectopic pregnancy? ectopic pregnancy, here the gestational sac lies outside the uterine cavity. Early pregnancy loss, that means the gestational sac is present inside the uterine cavity. Here the beta HCG, ectopic pregnancy, we have to differentiate by using beta HCG, by doing transvaginal sonography, and from clinical science, we can differentiate these things.
Hello.
Yes.
Yes, madam. We have completed with all the questions. And thank you very much for your valuable time and sharing some important insights on the topic.
Thank you.
Thank you, madam.
Okay.